I must say it's really it's great to follow two great presentations. They're also both presentations have a nice sort of larger perspective that in some ways makes it a challenge and in some ways makes it a special pleasure to be the discussant because I'm invited to attempt to play on the same high altitude playing field. I should say thank you, Richard. I really appreciated your jokes about the 50th birthday. Yeah, that's the cake from my 50th birthday party, which was 1 month ago. There are no jokes about prostates, I promise you. I'm also still mad at Dr. Konecka because her disgusting comments were just kind of, I can't equal that. When I thought about the issues that both David and Richard talked about, it goes back to some very intense memories that I actually had out there on the campaign trail in 2008 just talking to people. And one of my, in the sense, was the Affordable Care Act a promise kept to a lot of the people that I spoke to and a lot of other people spoke to? One of my first memories campaigning was I was brought down, I was a guinea pig to help develop the phone system for the Obama campaign. They had a computerized phone system. And so they asked me to call African American voters in rural South Carolina. Why they picked me for this job, I don't know. And one of the first people that I called was a guy who was an older man, and he started telling me about how he had diabetes and he was nearing retirement and his wife was sick and they had big medical bills. And he said, if this Senator Obama is elected, will he help me? And it wasn't sort of, can you send me a Will.i.am video link or, will he help me in some nice sense? It was really like I need help like right now. And it was like a punch in the stomach to be on the end of the phone trying to sell this guy as a voter and making the promise that we were going to help this guy. And, this was after we had seen the Clinton health reform fail and a bunch of other things fail. And in many ways, I do feel like that promise was kept, and for many of the things that Richard related. Although when I think about where this person is now, and I think about Howard Gleckman's presentation, I wonder, did we actually keep our promise to this man? It really depends on what his needs are. I think as Richard emphasized, the coverage expansions are really just a critical accomplishment for the American welfare state and for public health in a way that we don't always appreciate. I will say some things that Hank will say more about, that we're in for the ride of our lives in actually making this thing work. So let me start with the underappreciated triumph for vulnerable populations. I don't think that many observers appreciate how important the Medicaid expansion is, not just for the people covered, but for the content of coverage. And if you listen to a lot of people on the left, they say, there was no public option. This sort of looks like a warmed-over version of the Heritage Foundation's response to the Clinton health reform. We've all heard the critiques among the unenthusiastic supporters. And when I look at the charts that Richard generated and others, this is the most important substance abuse policy legislation ever, at least on the demand side. And it's arguably the most important HIV policy ever. Maybe the Ryan-White Care Act would rank with it. This is incredibly important. People are being covered under conditions of parity. And there were so many big issues happening that some of the really critical public health things almost went unnoticed, but they're very real. Now, I should say that one of the implications of this is that Medicaid will become the dominant payer for mental health and substance abuse services in the United States. And I don't think that the systems that we have are really ready for this. We know Christina Andrews actually recently got her doctorate and was supported by some Chaz funds, has just looked at the capacity of the treatment system to participate in Medicaid, and I've collaborated in some of that. The number of treatment facilities that say don't have computers to do billing or don't have a physician who just don't know how to interface with the Medicaid reimbursement system, it's enormous. Now, there's a good and a bad aspect of that. To be frank, a lot of these places should go out of business. There's a lot of really lousy care provided in the mental health and substance abuse system, and one of the goals of health reform is to give patients a real choice so that they don't have to sit out in front of that methadone clinic that does a bad job, in the morning when they can get a federally qualified health center to maybe provide the same service that's integrated with the rest of their medical care. But there are many unintended consequences we have to think about. So Tom Diano and I have done some work on HIV testing within the opiate addiction system. And one of the things that we found is it's more integrated than it used to be in regular medical care, particularly with the rise of new therapies like buprenorphine rather than methadone. But it turns out that the old safety net providers had a public health mission. And so we see dramatic declines in HIV testing among opiate clients because they're now going into integrated healthcare systems where HIV is just less of a prominent issue than it used to be. Now, is this something that this is something we have to fix? It's not something that's a fundamental defect, but it's something we have to track. And we have to think about how to bring new actors into these systems to care for vulnerable populations in a way that attends to many of the things that we haven't always thought about in the system. Now, we haven't dealt with all of the problems. I think one of the interesting aspects of health reform is a demonstration project to help to see, can we do a better job with the really long-term vulnerable people who have serious psychiatric illnesses? Since the beginning, Medicaid has refused to pay for specialized inpatient psychiatric care basically in a facility that has more than 16 beds, with the majority of clients being there for psychiatric diagnoses. As someone who takes care of someone with an intellectual disability, I was talking to some family members of people who had relatives with schizophrenia, and it was astonishing to me how much better the care was that we received than the care that these people received. And one person said the best thing that ever happened to her brother was when he got a really serious lung disease, and he could then go into a nursing home under the lung disease diagnosis when he could never get into the same home because of his mental health problems. So we still have some work to do, and I think that some of these demonstration projects hopefully will be helpful there. I'll say a few things just to emphasize Richard's points. Single childless adults are absolutely a key public health population. And I'll give you an anecdote from last night. So I was walking across the bridge across the river, and a guy just stopped me and asked me for money. And maybe that's happened to you in a big city somewhere in America. And yeah, you might think, well, this person, maybe he has a substance abuse problem, or maybe he has a mental health problem. And you think, who's going to pay for the care for that person? And if you say, what's going to happen in 2013, the answer is, well, I kind of don't know. It's a patchwork of safety net services, and even if you find someone to treat the person's substance abuse, that person might not be the same person who could take care of his diabetes or the other problems that person has. And, he's not a vet. He's not a mom. Maybe he's a vet, but he doesn't qualify for veterans disability. He doesn't have a federally qualified disability that would put him on SSI or SSDI. So he doesn't qualify for Medicaid. Well, after 2014, these people all qualify. Give you another example. This is another hotel in town. This is the Cook County Jail. And I'm the co-director of the University of Chicago Crime Lab, and so I do a lot of work here. And there's about 10,000 people on any given night, and about 2,000 of those people have significant psychiatric disorders. You could argue it's the largest psychiatric facility in the Midwest. And so it turns out that many of the people who are Medicaid eligible who have serious psychiatric disorders, they can actually move out of the jail and either put them in community-based mental health systems, maybe with an ankle bracelet, or they can put them in an inpatient facility. But the capacity is very limited, and it turns out that there are a lot of people that most of the people are just not Medicaid eligible, and they're basically staying in the jail because there's no place to send them. So they're literally locked up because they don't have health insurance. And right now, about 90% of the inmates are not Medicaid eligible. It's changing slightly because of a county program. By 2014, 90% of the inmates will be Medicaid eligible. And I talked to the county sheriff, and he said that the ACA has the potential to be a game changer, ending the state, federal, and city budget cuts that have made the Cook County Jail the provider of first resort in the city of Chicago and Cook County. This is what it looks like on the ground for one vulnerable population. I should say no one in the criminal justice system knows that much about Medicaid, and one of the challenges we have is to just tool people up to do this, and also get them involved in the policy conversation at the state level so that they can write the proper legislation so that we actually deal effectively with these difficult-to-serve populations. I think that these 3 points are obvious. I actually think, in a way, the Supreme Court decision has served one valuable function, which is it's a great put-up-or-shut-up moment for a lot of governors around the United States. And actually, one of the challenges here for both the Obama administration and for the states is to find a dignified path for the states to take the money. And if President Obama called me up, I would say be really mean to the Republicans in the House and be really nice to the governors in the states who actually have something at stake in making this thing work, and you have to work with. Some concerns that merit attention. I do think that the disability and long-term care issues that you heard about this morning are so significant. And the ability of the various mechanisms in ACA to truly care for the disabled is unproven. It is, as I mentioned when I made a question, as a caregiver, you're very, very risk averse when you're caring for a disabled person. And we hear a lot of attacks on Medicaid, but the reality is if you have your disabled relative on Medicaid, the bills get paid, and you're not going to go broke. And we're very grateful for that. And if someone says, maybe you should move into a health insurance exchange or some alternative mechanism, boy, that's a hard sell. Because when you get very large medical bills coming to your house and it's stamped, this is not a bill, Medicaid has paid it, you get a bunch of those, and somebody says, gee, maybe we should change your plan, it becomes much less attractive. I won't mention the implementation challenges because I won't have time, but there are quite a few of them. I think the biggest concern is it's the most complicated piece of legislation in memory. And there's no opportunity to fix many of the problems that we're talking about today within the political environment that we're in. And in a weird way, we're hostage, in a political way, to exogenous events that really have nothing to do with health reform. When I saw David's charts, I was thinking, boy, health reform will be a big success if, for reasons that have nothing to do with it, healthcare costs go down. And if healthcare costs don't go down for reasons that have nothing to do with it, boy, are we in trouble. And healthcare will be blamed. Healthcare reform will be blamed. Let me give an analogy about this legislation, then I'll close with a few things about David's talk. So, Margaret Thatcher just died. She didn't have a birthday party for Richard to make fun of. But when I think about the glorious victory that they had in the Falklands, maybe some of you are not old enough to remember that, but it really was quite remarkable. They took these ships, they sailed all the way from England down to the Falklands, and they fought this amazing battle and actually won one of the great military victories that, in 20th century history. And they did it, and it was great. And there was also a sense, this is never going to happen again. In fact, it turned out they had sold the aircraft carrier. They had to sort of rent it back, I believe, in order to fight the war. And you know what? That's how, if you go to a typical congressperson, you say, what do you think about ACA? They kind of look a little like, wow, we've just been through something. And this was after ACA actually passed. This is not like the Clinton health reform where people have this understandable reaction because it failed. What lessons are future presidents going to take from this when we think about the large challenges that we have in healthcare and non-healthcare? I think that if I'm the Rahm Emanuel talking to the Barack Obama 5 years from now and somebody comes to me and says, we have climate change or disability, I'm going to say, don't do it. What's it?
That's what he said this time.
Yes, he did, exactly. And it is, and that is the dysfunction of our political system is just so profound, and it's such a deterrent to tackling big questions. Now let me get to David as I close out. I thought it was a really fascinating set of stylized facts, and I think there's a real possibility that we've bent the cost curve, or at least someone's bent the cost curve in some way, and there are enormous implications. And I think that understanding that these baseline projections that we work with are fundamentally uncertain. And I think, especially as an antidote to the rhetoric of short-term crisis, it's really important. Now, how much we can count on that is another question. So I look at this chart, and I think, medical care only might ruin the economy. That's really good news, David. Thank you. But the thing is, it can still wreck the federal budget long before it wrecks the economy. And that's a really sobering thing. And I'm still pretty freaked out after seeing your slides, and I wrote this slide even before I watched the earlier one, because even a somewhat more optimistic path of healthcare expenditures will still enormously damage the federal government and the discretionary component of it. And we can't plan on the basis that we're going to bend the cost curve, or that we'll bend it fast enough or deeply enough to really matter. And one thing is, when I looked at this graph from CBO, the real problem here in a lot of ways is not that big line heading off into infinity. It's that dotted line that's the revenue line. And, we really need more dollars in the cash register. There's only so many ways to say that. It's partly repealing some of the tax cuts. It's partly finding new elements such as a VAT or a carbon tax. And this is where my pessimism about the political system is really coming into play, where we just cannot seem to address or even to really prioritize what has to be done to stably finance the welfare state that we obviously want as a society. And the idea that we can have blue state expenditures and red state policies on the tax side is just not a sustainable equilibrium. And so I'm optimistic in the sense that today is a better day than tomorrow, but I really worry about the long-term future of our fiscal health, even if you're correct in your optimism. So thank you very much, and I'll stop now.
Hi, I'm Jonathan Cohn from the New Republic. And the first thing I need to do is, David and I have been talking about this for a long time, and I feel like in front of all these people I need to fess up and say that yes, David was right, that we could lower healthcare costs. I've been among the skeptics, and in public forum I feel like I should do that. Actually, I thought the adjustment for the recession and the other statistics were very interesting. I wanted to ask you, are you worried that, and we talked a little bit about this before, but I'll give you more chance to answer it. Are you worried that with the readmissions, the spending is going to show up somewhere else? And just to give you an example, taken from a hospital system I know, not to reveal the name, but I live in Ann Arbor. I know some physicians who work there, and I've heard stories about how, for example, someone comes into the ER after they've been discharged, and they get put into observation. And they sit in observation for 2 days, and they're kind of borderline. And then they leave. Now, they don't count as a readmission, but they've been in the ER in observation for 2 days, and that's going to run up some pretty big costs in this hypothetical hospital system that may or may not be near my house. So I was curious, are you worried about examples like that showing up? How confident are you?
Yes, one of the things that we've learned is that when you deal with only one part of the healthcare system, things show up elsewhere. The beauty of what we're trying to do now, at least, is to move into bigger levels so that sort of the money can't escape, right? I mean, if you look at what all the ACO type things and all the rest of it are trying to do, is basically move into a level where there's sort of no out for it. So I suspect that's not the bulk of what's going on now. Although I wish they would make the data available so that one could actually look at it, but certainly if we're flexible in the payments, or if we're good in the payments, that won't happen.
I have a comment and a question that in a way harkens back to the previous session, so it may involve some of those participants. The comment is on the projections that Harold found so disturbing that David presented. We're all in enormous debt to the Congressional Budget Office for doing a quality of work that otherwise wouldn't be done on matters such as budget projections, and it's a great organization. That said, the long-term budget projections that drive so much of current discussion incorporate a number of systematic assumptions that present a highly misleading and needlessly dire indication of the future. And I'm going to mention just 3 of them. The first is on that tax line that Harold mentioned. It's at a flat 18.5% of GDP. What does that mean? Well, Congress raised taxes this January relative to the current policy, which is built into their projections. How does that affect those long-term projections? Well, it doesn't. You raise taxes and there's no effect because you are recurring to 18.5%. There's no bracket creep allowed. That's part of current law. Taxes will go up as a share unless Congress cuts them. So we're building into the projection the assumption of continuing tax cuts in the face of large budget deficits. Is that reasonable? I don't think so. There's another area which is more controversial but more portentous in the long run. Under current law, it is illegal for Medicare Part A or Social Security to spend any money beyond what has been accumulated in the trust fund and current revenues. Both programs are projected to have the trust funds become exhausted. CBO assumes that spending will continue beyond the legally authorized level. If somebody came along and said, well, maybe that's not the right thing to do, there are a lot of people who just would not take that projection seriously. But these projections indicate a problem that exists, but they do not indicate the expenditures that current law or even current policy permits, because current policy is solidly established in not permitting expenditures beyond that level. We've had a series of crises that were dealt with on all of that. A continued and sustained slowdown in the growth of healthcare spending, as David pointed out, is not allowed for in these projections. We take it down. There are two CBO projections. There are slightly different procedures in each one with respect to healthcare, but beyond a certain point, it bops back right up to that excess cost growth assumption. The world looks rather different if those are changed. So this is all a desperate plea to the extent that anybody at any time has any capacity to influence the way in which CBO does those long-term projections, that these deserve serious scrutiny. And I will tell you that there will be forthcoming from highly respected organizations projections that indicate we are very close to dealing with our long-term budget problem under current law. So this is the comment. The question relates to disability insurance, Social Security disability insurance, which is financed by an earmark tax and a trust fund that is going to be exhausted in a couple of years.
2 years.
At that point, something has to happen. And in light of the previous discussion and in a way this one, it's sort of an elephant in the room whose name or presence has not yet been acknowledged. What do you predict? What do you recommend? It may be the basis for another conference, so we could argue.
I'll start on that one. There's sort of two sides to the prediction. I think one side is that because SSDI is so small compared to the overall Social Security plan, they can borrow within and at least stave off that thing. So I predict that will probably happen a little bit. Let me give you my Pollyanna prediction. My Pollyanna prediction is that there will be something done to both bring in some more revenues and also to do something to sort of change the way we govern the front door. And what I'm hoping it is not by essentially closing the front door as has been proposed, but rather that we sort of target some of the learning that we've had on early interventions so that we can actually start to fund some early program through some combination of insurance reform and then sort of some supplemental funds to particularly targeted at mental disorders and musculoskeletal because there seems to be a portion of both those populations where if you intervene pretty early, you can change their path into disability. So on my good days, I hope that will happen, and the evidence that I've seen suggests that there's some possibility of actually making a difference by doing that.
I'll just make one comment on that. I think also that beefing up the continuing disability review process and just Congress has been slamming this program but doesn't want to allocate the money for the capacity to really implement it properly. And I think in a couple of these diagnoses, there's probably just a need to beef up some of the review process to make sure that it's doing what it's supposed to do. And
So to stay on schedule, I'm going to take one more question. Let's take the front row.
Thank you. Dave Ennis, I'm another nobody. We need to hang out together.
And distinguished graduate of the CFAP program.
72 graduate of the health administration program. At the time, the big crisis at that time was that healthcare expenditures could exceed 10% of the GDP. And that was the huge issue when I was in the program. And in any event, I can't think of anything more important, David, than understanding the dynamics behind this recent decline in the rate of growth in health expenditures. What is the hard evidence for each of the three areas you've identified, and what can we expect in terms of getting hard evidence, and how long is that going to take, and when will we begin to understand what's happening?
Well, I wish I had good news on that. Some of the data lives in Baltimore, I suppose it is, and it's difficult to pry out from there. Other kinds of data, like the issue that John Cohn was raising, you probably, I think we'll get some of that with kind of electronic medical record data, so we can see exactly why people went to the places that they did, and we're sort of accumulating that rapidly. But my general sense is that we're always going to try to be playing catch up. Although I should say in Massachusetts, we've invested in data, and we're investing a lot more in it so that we can be able to provide this kind of real-time information on what's going on. And I expect more states will try and do that as they get very nervous, but we're not there at the moment.
Gene, is there any way
As
to
a
take
real
another-
quick follow-up, as an example, I have Medicare. The rate of growth of Medicare expenditures declined
Yes.
at an equal rate to commercially.
Yeah, actually a bit more
More.
because of payment changes in Medicare too.
And that would infer that the price sensitivity issue isn't much of a factor then.
I think the Medicare has gone down more in part because of payment changes, like, for example, reducing the Medicare Advantage payments and reducing the hospital update factors. So you'd need to factor those out before you looked at some of the price.
So time for lunch is the good news. But before that, let's give our panel a